Hi guys, I'm Jason. I'm one of the second year, soon to be third year medicine residents. I'm going to be just talking a little bit about Afib with RVR and kind of what you should know as a medicine resident on the floors if this happens to one of your patients. Okay, so when we talk about Afib, that's an aberrant conduction that usually begins in the pulmonary veins that triggers fibrillation in the atria. And more often than not, it's a symptom of an underlying disease. Most of these patients have hypertension, coronary artery disease, or some other type of underlying systemic disease which predisposes them to atrial dilation and subsequent abnormal rhythms that tend to develop in the pulmonary veins. And this is important to know because it's atrial fibrillation, since it's a trigger of an underlying disease. When patients go into Afib with RVR, you really need to know what other comorbidities that they have so that you can appropriately prevent them from going back into Afib with RVR, and also so you know how to treat them. There are a few basic treatment principles for atrial fibrillation. SANS, RVR, and those are primarily rate or rhythm controls. And we have two really big studies that help kind of guide therapy. These are the FIRM and RACE-2 trials, which basically said lenient heart rate goals of 80 to 110 are appropriate for atrial fibrillation and provides similar outcomes compared to rhythm control. For those that can't tolerate being in atrial fibrillation, even when the rate is controlled, there's always the option of chemical or electrical cardioversion. And then in addition to rate and rhythm control, there's also the anticoagulation to reduce the stroke risk. And you generally use the Has-Bled score to evaluate the risks of major bleeding and balancing that with the risk of stroke or CVA in terms of their CHA2DS2 VASc risk. We look at some of the causes of atrial fibrillation. Here's a little kind of silly mnemonic, Pirate C, for the different etiologies that can contribute to developing atrial fibrillation. P is for pulmonary causes such as COPD or PE. I is for ischemia, generally in the setting of coronary artery disease. R is for rheumatic disease, mitral stenosis. A is anemia, thyrotoxicosis, alcohol, sepsis, stimulants, and then finally the C is for heart failure. And it's important to know why we actually treat Afib with RVR. A lot of times these patients can be asymptomatic when their heart rates, are in the 120s, 130s. They may be completely asymptomatic, but the goal here is twofold. One is to prevent hemodynamic instability. These patients can quickly decompensate. And then the second issue is to prevent tachycardia-mediated cardiomyopathy, which over time can just make things worse for these patients. And when we talk about treating patients that are in Afib with RVR, the first step in a treatment algorithm is always, is the patient stable or unstable, because that dictates everything that you will do. And generally for me, RVR is generally a heart rate over 120 or so that has been sustained. So when you look at these patients, you want to look at their vitals, you want to know what their heart rate is, what their blood pressure is, you want to know the heart rate trend over time. Hopefully they've been on telemetry, and you can just graph it out over the past 24 hours to see where they've been. You want to know if they have any symptoms, if they have any palpitation, shortness of breath, lightheadedness, dizziness, anything. And then if you have time, you really want to do a quick bedside exam. If you get called by a nurse saying someone's heart rate has been in the 130s, 140s, and they're stable, before you do anything else, just take 5 minutes, listen to their lungs, listen to their heart, check for JVD, see if they're mentating appropriately, and that'll kind of give you some insight into how long you have to think about it before you have to act. And then you will also want to know, when you're going through this brief chart review, when their last echo was, when their last stress test was, do they have any evidence of structural heart disease? And you kind of want to put all that together before you go in to treat the patient. And so here's just an EKG. Generally, one of the first things you'll do is get an EKG, especially if they're not on telemetry. And this is just showing Heart rate, 150s, 160s, irregularly irregular. That's really consistent with atrial fibrillation with RVR. And then so say you get to the patient's bedside, they're hemodynamically stable, their heart rate's 120s, 130s. They have absolutely no symptoms at all. What can you do? Try PO meds. You don't have to push IV medications for AFib with RVR. Oral metoprolol usually starts working in the first 30 minutes. You get the peak concentration after about an hour. And so if they're already on, say, 50 BID of metope, you can give them another dose of 50. The maximum dose of PO metope in a day is 200 milligrams. And just know that you can give it every 6 hours, every 6 to 8 hours, and then you also want to know what is causing them to be in atrial fibrillation with heart rates that high. Do they have chronic AFib and you just reduced a beta blocker or calcium channel blocker when they came in the hospital? Or, did they come in with a heart failure exacerbation? Maybe they've been meeting their diuretic goals. And you need to give them some Lasix with that PO metoprolol. When they're hemodynamically stable, but their heart rates have, have been sustained over 130s, maybe they're even in the 140s, and they may or may not have symptoms, that's when you start thinking about IV medications. Generally, the first line agent that you're going to use is IV metoprolol. Usually give it 5 milligrams IV up to 3 total doses, generally 5 minutes in between each of the IV pushes. Special things to consider is if a patient is already on really high doses of metoprolol. For example, if they're on 200 PO of XL, they don't respond to the 5. The second dose, you can use 10 milligrams and push, just because their beta blocker, they could just be oversaturated and you might not get an effect. But if the metope breaks, just chase it with PO metoprolol. Alternatively, or as a second step, you can use DIL. At Yale, what we generally do is just give a one-time push of, or not one-time push, or first push of 10 milligrams of IV DIL, which is actually a little under what, so there's a study that was done in 1989 that was published in Journal of American College of Cardiology that actually developed the guidelines for pushing DIL in atrial fibrillation. And in that study, they actually pushed 20 of IV DIL, waited for 15 minutes. If there wasn't a response, then they gave 25 milligrams of IV DIL. In that study, 94% of patients actually broke in that treatment algorithm. And they actually tended to use patients with what we would sometimes consider soft blood pressure. So they used a systolic cutoff of over 90. And then hypotension only occurred in about 13% of those patients. I know one of the big concerns on the floor is when you're pushing IV metope and IV DIL, are you going to drop their blood pressure? There's always the risk, but generally that risk is higher with DIL. And it's really only about 1 in 10 or maybe even 1 in 9 patients that will get a little hypotensive with that. And then again, if they respond to DIL, you want to chase it with PO DIL. Initial treatment dose of PO DIL is 30 milligrams. You do that every 6 hours. And then the maximum dose of DIL in a day that you can go up to is about 360 milligrams or so. If at any time they become hemodynamically unstable, their blood pressure is in the 70s, they're a little confused, just go right to cardioverting them. There's no sense in kind of waiting around and waiting for things to get a little worse. Some special considerations, and this has come up a lot on the floor, is, so you have a patient with a diagnosis of heart failure. Are you allowed to give metope or DIL? What do you do? And so DIL does have a negative inotropic effect, and it should be really used in cautions with patients with advanced heart failure. And here the key is advanced heart failure, and that's New York Heart Association class 3 or 4. And what I did here is just put the definitions. And so this isn't your average patient that just comes in with a little worsening dyspnea, some shortness of breath, you're diuresing them on the floor. This patient's generally like class 1, class 2 heart failure, but these are class 3, 4 heart failures are ones with very advanced heart failure. And in these patients, they're probably already being followed by cardiology. You might want to just touch base with them. But generally, you could try a little bit of metoprolol to help them out. And then if that doesn't work, consider asking cardiology. Another consideration is a lot of times you'll have patients in the ICU on pressors that go into AFib with RVR. If they're on levo, just remember it's a beta agonist. So if you're giving them IV metoprolol, it's kind of counteracting the levofed that they're on, so their blood pressure might or probably will drop. You can consider amio for that instead. And then one thing that has come up with me and that kind of caused me a scare as an intern in the MICU is, I had a patient with AFib. They went in AFib with RVR, but it was a cost-coverage patient. I didn't know they had a known left bundle. And I got a call from a nurse saying that the patient went into VT. Before even looking at their EKG, if you just look at one, like I think for their tele lead, it was like V1 or something. And if you just look at V1 and you have a tele strip of that, like, yeah, that looks like AFib with RVR. I mean, not AFib with RVR, excuse me, that looks like monomorphic VT. So just really go back, look at old EKGs. If they're stable, take some time, look at it. You can see that if you march out the QRS, it's actually irregular. Look back at old EKGs, confirm it's AFib with RVR, and just kind of reassure everybody that this is not monomorphic VT. So now that you've stabilized the patient, you just want to make sure you kind of cross all your T's and dot all the I's. And just kind of reassess them. Do they have any clinical evidence of heart failure? Because if they do, they're just going to keep going into AFib with RVR unless you get the volume off. Are they, other things that have come up sometimes, are they being treated for COPD exacerbation? Did the continuous NEMS you put them on precipitate this? Are they septic? Did they have any new EKG changes concerning for ischemia? When was the last time you checked their TSH? About 5% of patients that go into AFib with RVR will have that from a thyroid issue. And then just a brief summary, you guys as medicine residents should be able to handle this. Generally, you don't need to call cardiology. IV metoprolol is first line, followed by DILT, cardiovert if the patient is unstable. And then you always want to kind of reassess everything and treat the underlying cause. Thank you.
Oh, that's awesome.